Thank you very much for giving me the privilege of saying a few words to the British Transplant Conference. This month marks the 21st anniversary of when Lou Cavusi and I did the first laparoscopic live donor nephrectomy at Johns Hopkins Bayview Medical Center. Initially I was asked to comment on what my thoughts were at the time, and initially I was kind of skeptical. Lou Cavusi was much more prescient than I was. He thought that this was going to be a big thing and that it would have a huge impact. I was not so sure. And, our goal originally was to remove the financial and logistical disincentives to live donation by decreasing hospital stay, decreasing pain, speeding recuperation by applying minimally invasive techniques. We did the first case, and the donor went home on the first post-operative day, which was unheard of for those times. And within 2 weeks, he was back to work, doing very physical work as a welder. And at that point, I said, this is going to be something big, and people will eat this up. I was not at all prepared for the degree of controversy that this operation was going to create at the time, or how much negative reaction we would experience. But the first 2 years that we were doing this operation, I literally had nightmares every night about what we were doing, that we were going to hurt somebody or kill somebody. But things worked out, and we persevered.
So you heard that clip. He's one of the most eminent transplant surgeons in the world. He had nightmares for 2 years after doing this operation, thinking he might, kill someone. So, and his concerns were entirely justified, because this is an operation done on a well patient. Apart from the emotional reason of giving a kidney, we're actually causing that patient harm. In fact, there's a risk of 1 in 3,000, a risk of death on the operating table from that operation. So clearly, he had concerns. And as with anything new, even in surgery, it's quite hard to accept initially. However, if we think about the real sort of benefits of keyhole surgery compared to open surgery, it really lies in less post-operative pain, shorter hospital stay, and better recovery, and that's across all general surgical operations. And indeed, from our work looking at keyhole operations for living donor transplantation, which we published in 2012-2009, you can see that this patient here had a keyhole operation, 3 weeks recovery time. This patient had an open operation to give a kidney, 12 weeks recovery time. This patient stayed in for 3 days. This patient stayed in for 7 days. So you can see there's a real difference here that we're seeing with the advantages of keyhole operations. And of course, that influences the willingness of donors to then donate, including altruistic donation. But can we go even more minimally invasive? And the answer is, we probably can. Now, Einstein said, if at first the idea is not absurd, then there is no hope for it. But we're not all Einstein. So we need to think about that a little bit carefully here. So here's an operation that's taking place with 3 instruments in 3 different ports. This is for the removal of an adrenal gland, which is a gland that sits just above your kidney. Can we combine all that into one? And actually, yes, you can. You can put all 3 instruments into a single port with a single incision to do the same operation. And that requires a different level of skill. It's a harder skill to learn because you've got less maneuverability, as you can probably imagine, with your instruments, and less space, less triangulation. But the advantages are that there's a smaller scar, just 1 scar, better pain control, and potentially better blood loss. And of course, that operation has taken place for taking your appendix out, operating on your colon, even taking your kidney out. And Gabby Aniscu in Edinburgh is developing that in the UK for living donor kidney transplantation. Now, what about natural orifice surgery? What do you think about that? Now, this is essentially still fairly experimental, but this is operating through a natural orifice. So essentially scarless surgery through your mouth, through your anus, or through the female genital tract. And we work quite closely with Professor Modi, who's a professor of transplantation in Ahmedabad in India, and he's done he's got the world's greatest experience actually of robotic and kidney transplantation, which I'll come on to later. But he's done 40 of these transplants where he's put the kidney through the female genital tract and completed the operation through keyhole surgery. So essentially it's almost scarless. And the patients have done very well. And he's published that in the American Journal of Transplantation. And it has still yet to be accepted on an international level, but still, perhaps we need to be more open as surgeons to these innovative approaches, and perhaps they're not as bad as they seem after all. So, moving on now to robotics and robotic-assisted surgery. Now, this really refers to surgical technology that places a computer-assisted electromechanical device, if you like, between the surgeon and the patient. But the surgeon is still in control of the robot. So this is a robot, the kind of system that we use at Guy's Hospital, the Da Vinci robot. So here's a console, the surgeon sits here, the robot is docked at the patient's bedside just here. Here's an assistant who changes the robotic instruments. So it's a master-slave system. Now, what was the big fuss about robotics? Why did everyone take to it? What's the advantages of robotic surgery? Well, there are a number of advantages. The first is that when the surgeon looks through the console, it actually restores the three-dimensional vision that's lost on a standard keyhole laparoscopic computer screen, the standard laparoscopic stack. So that's the first real advantage. It's absolutely fantastic views, and I've got some videos to show you on that. The second is that it filters out any hand tremors. Now, we all have a hand tremor. I've got a natural hand tremor, depending on how much coffee I had the night before. But obviously that can still happen with laparoscopic instruments when you're operating. So the robot has a way of filtering out the hand tremor, which is really very useful. Thirdly, the robotic instruments have more degrees of freedom of movement than the standard laparoscopic instrument. And I've got an example of one here. Hopefully you can see this. So this is a robotic instrument just here. Okay, and you can see you can move it in almost 7-degree rotations and different degrees of freedom of movement, which you can control at the console. Okay, that's the robotic instrument. See that? That's quite cool, isn't it? Goes all the way around like that. So, and this one here is a laparoscopic instrument, which is essentially just got that, and you can turn it with your fingers. Okay, so that's, again, you can have a look at these later on. But you know, that's one of the great advantages. So the robotic instruments are trying to essentially replicate the movement in the human hand, the wrist articulation. And importantly, a surgeon sitting at the console is obviously going to be less tired than a surgeon standing up in a difficult position with laparoscopic instruments for a very long operation, or a very long open operation. So some of our transplants can take up to 10 hours, a combined kidney pancreas transplant, and that's a long time to operate. So the advantages of a robot is that the surgeon can sit down in a comfortable position and operate through the console. It's an important thing to think about in long surgery. And we did the UK's first robotic transplant back in September 2016. So this is our team. So this is Professor Mahmood, my supervisor who led the team. This is Nikos Kasaris. And this is Professor Modi from India, who came over to provide us with support and mentorship for the program. So he's got the most experience of robotic transplantation for kidneys in the world. He's done over 300 of them. And I must say, working in very limited resources. So he's a quite remarkable individual. But you can see Professor Mahmood there working away at the console, and this is our theatre setup here. So I'm just going to show you a video now of some aspects of robotic kidney transplantation, and I'll try and take you through this. So here's the theatre setup. You can see there's the robot docked there at the patient's bedside. There's the assistant surgeon who's going to change the instruments. So these are the robotic ports in place. You can see that there's the gel port that we use to put the kidney into the abdomen to do the suturing. So there's the actual kidney being removed from the donor now. It's been removed, and it's got some gauze around it, which we can use to manipulate the kidney inside the abdomen. So there's the kidney now. It's going to be put through to the gel port into the abdomen. And these are the robotic instruments at work. So what we're trying to do here, or what Professor Mahmood is trying to do here, is to essentially dissect out the external iliac vessel, which I was telling you about earlier. So we have to tease away all the tissues around the blood vessel. You can see how the vision is excellent. The robotic instruments are working away very nicely. and he's trying to isolate that vessel completely so we can stitch the kidney onto it. So there's the vein. We open up the vein first. It's got blood in it, which we need to get rid of. So he's doing a venotomy now, so very delicate movements there. So the kidney is now in position in the abdomen, and this is the vein from the kidney, the donor renal vein, and we're going to attach that onto the recipient's renal vein. And here you can see the robotic instruments working away just like your hands would work away to stitch that vein very carefully onto the recipient's vein just here. And you can see the movement of the needles there. And do you see how the curve of the needle follows through quite nicely with those robotic movements? And that anastomosis is now complete. We then do the same thing for the artery. So this is a slightly smaller vessel just there. You can see the needle coming through there. There we go. And we stitch that on, secure that. And now is the moment of truth. We take the clamps off the blood vessels now. We're just going to let blood back into the kidney. In a minute. There we go. So that blood vessel there is now pulsating. It's got blood going in. The kidney now should look pink. And there we go. It's full of blood, looking pink. Very nice. And then we take this gauze off carefully. Those are the scars. 1, 2, 3, 4. About 2-3 centimeters. And a small scar here just for the kidney. And normally would go in a big scar like that. That's the team. So, how quickly do you think the patients went home? So our first 2 patients went home within 4 days. So, and normally they'd stay in for about the best part of a week to 10 days, actually, if not longer. And this lady actually, her first kidney transplant through the open operation, and then when she had it robotically, she said it was 80% less pain. And Professor Modi's patients go home on paracetamol. So, can it be done in children? And indeed it can. So, again, Professor Modi has done about 30 of these cases in children, and they go home also within a few days, and we're hoping to start that program too at Guy's in the future. But there are problems with robotic surgery. It's expensive, and secondly, there's no real haptic feedback. So, what do I mean by that? Well, the hand is the surgeon's best instrument. We rely on an interaction between our tactile and kinesthetic receptors to really give us that vital feedback to perform quite delicate surgery. It really is the surgeon's best friend. So what are we doing to try and improve haptic intelligence in robotic surgery? Well, various devices have been successfully developed by the UPenn Robotics Lab. This is Professor Kutschenbecker's work. She has essentially developed these instruments that you can lock on to the robotic arm, and that gives the surgeon realistic vibratory feedback. So you know what it's like to actually put your needle through a particular vessel. It's giving you feedback. I remember a cardiac surgeon once telling me when he was doing open surgery, sometimes he can't even see the blood vessels, and what even with his loops, they're so small and so calcified, he just relies on the feedback he's getting from the needle as it goes through a calcified blood vessel, so he knows he's in the correct plane. But that takes years of experience, to develop that tactile recognition. But there are instruments that are hopefully out there that are helping with robotic surgery. The good thing is you don't just sterilize them, and it doesn't interfere with the robot. This is quite interesting. This is the haptic glove. Now, this has been developed by King's College London and Neurosurgical Technologies, and they've essentially developed this glove which can remotely feel whatever the robotic instrument is touching inside the body. So if it's a prostate with a cancer on it, it feeds back signals into this glove, which the surgeon can then almost just feel that entire prostate gland in real time, as it were. And that, again, is something that's quite exciting and might be translated very soon. So, we've seen essentially how minimally invasive techniques have provided the incremental progressive steps towards the ultimate quest of trying to perform a safe operation with a small scar so that patients can go home quicker. But can you actually do an operation, do you think, in the future which is completely painless, no complications, done by a robot, completely on its own? How far away are we from that? Well, I don't think we're too far away. So this is quite interesting. So this is the world's first feeding robot. It actually eats and has its own digestive system. This is from Professor Winfield's laboratory in Bristol. So it generates its own energy. And this robot can actually pick up objects of differing consistency, relying on its own haptic intelligence, completely autonomously. So these advances in integration of haptic intelligence and tactile feedback will undoubtedly, I think, be translated into the future of surgery. But it's important to remember that a fool with a tool is still a fool. Okay, so what I mean by that is outcomes in surgery are surgeon specific, not technology specific. You can change technology in a day, but you can't change mentality in a day. That takes generations. So how do we train this fool? How do we train the surgeon? And again, that's a very important element. I just want to touch on that very briefly, because that really is a whole new lecture in itself. But essentially, training is a combination of three things for surgeons: cognitive factors, your decision making; personality traits, can you work in a team, can you communicate in a team, and your technical skills. Now this really, we can all sort of try and do, but these other two factors are quite important and quite difficult really sometimes to assess and to train in. You probably all remember the case of in 2009 where the pilot, I think his name was Sully, took off from LaGuardia Airport and was flying, and about 2,000-3,000 feet, I think, a flock of geese came into his engine. He lost all control, and then he had to turn and land in the Hudson, or rather he had to make a decision within 2 minutes whether to crash into Manhattan or risk his own life as well as everyone on board to crash into the Hudson. It's a similar thing with surgery. We can all have Sully moments, and I'm going to show you one now. So this is a real clip, a real operation taking place, and this is a living kidney donor nephrectomy. So we're taking a kidney out for living donation. We're at a critical point in the operation now, where we're going to ligate and divide the blood vessels attaching the kidney to the aorta and IVC in order for us to take the kidney out. And we do this with laparoscopic instruments. Let's see what happens. So there's the instrument there, there's the artery, there's the vein. We're trying to divide the artery first. There's your stapler going in. Oh dear. Okay, that for us is a Sully moment. Okay, so that's a real problem. That's suddenly you're faced with a life-threatening situation. So that patient can exsanguinate and bleed within a few minutes. So that's when all our skills and all our training as surgeons are really put to the test. What do? Do we open up the patient quickly? Do we try and correct it with laparoscopic instruments? These are the decisions that you have to try and make. So how do we train for that? And how do we actually develop confidence to deal with that situation? Thankfully, in this situation, my boss actually managed to stop the bleeding of that stump, which is directly off the aorta under systolic blood pressure. So he had to put in another stapler, and one that worked, and actually just managed to stop the bleeding, take the kidney out safely, and both the donor and recipient did very well. Okay, so this is when I now come to some audience participation. So how do we train? So I have a simulator here. So perhaps, James, could you change to the simulator? Great. Okay. So this is very kindly given to us by Semendo, which is a laparoscopic training simulator company, and we as surgeons train on this. So here's one example of the kind of skill that you might be expected to do. So let's see if it works. Yeah, maybe we'll just go straight to the